Good morning, everyone. My name's Anne Hunt, and I work for the National Academy of Social Prescribing. And we are totally delighted to to welcome so many people to our first meeting of our Evidence Collaborative and our first Airmeet as well. So bear with us if the technology is glitchy, but it looks really, really exciting. What we're going to do is I'm going to give you a brief introduction to the National Academy of Social Prescribing. Then I'm going to very rapidly hand over to our academic partners. So Karen and Lucy are going to talk to you about what they've been doing over the last 7 months and share that with you and open it up for questions and answers. And then they're going to hand over to Marie, another one of our academic partners, who's going to run a bit of an interactive session with you to work out how we can best work together going forward to support this work in advancing the evidence base for social prescribing. And then we're going to release you to more networking at the end. So I'm not going to hold us back anymore. I'm going to very quickly share my screen, if I may. Let's hope this works. There we go. Share. I hope you can see that. I'm going to keep it on that format, actually, so you can see the bits down the side, just because otherwise there's an advance, which is really annoying. So the National Academy of Social Prescribing was created in late 2019 by our Secretary of State for Health here in the UK, and it was dedicated to the advancement of social prescribing through promotion and collaboration and innovation. And a really important part of our role about raising the profile, developing innovation, is understanding the evidence, what we know, what we don't know, and sharing that more effectively. So that's why evidence sort of sits at the heart of everything that the National Academy is trying to do. And in a sort of nutshell, it looks a little bit like this. So this is an academy that works at different levels. So internationally, we're now working with the Global Alliance for Social Prescribing. Nationally, we have a number of projects in England largely, but also across some of the other sort of UK nations to accelerate innovation. And then working very locally as well through things like our Thriving Communities programme to make sure we develop those partnerships and that innovation very, very locally as well. Evidence underpins all that, and then we use all that information to make noise about it. So at that point, I'm going to stop sharing my slides and hand over to Karen to tell you more about the exciting stuff that we've been doing.
Thank you very much, Anne. So the main majority of this session this morning is going to be me and Lucy talking to you about what we've been doing over the last 7 months. And then once we've completed that, we'll have some time for questions and answers. So please do feel free to put those into the chat or the Q&A section. You can upvote other people's questions as well. So if somebody's got something in there that you're interested in, please do tick that if we come onto it at the end. I'm just going to share my slides now, so that will take a couple of seconds. I hope you can all see those. So talking to you today, as you know already, is Anne Hunt from the National Academy for Social Prescribing, Lucy Cartwright and I representing our academic partners collaborative that I'll say a little bit more about in a second. We represent quite a large team. So I wanted to start by saying a little bit about what we think social prescribing is, and that's not because I don't think there's a single person on this call who doesn't know what social prescribing is already in great depth, but because it frames a lot of our work. So for us, social prescribing is a pathway to relationships that link people to things in their community for health and well-being. And that's very different to being a single complex intervention or a single intervention. And it has implications for what good evidence looks like. So for us, the components, there's obviously individuals, people who have a need. There's a referring organisation or a referrer, that's often primary care, but can be myriad other people or organisations. There are link workers, and they obviously have very different terminology that relate to them, but they're individuals who make that link or facilitate those links. And there are the activities that people do in their community, often in voluntary or third sector. And those four things together make up social prescribing. I should make it clear that this isn't a final diagram. Lots of people disagree with it. This is, it's a point that we jump off from. And the four things in that diagram are ideas rather than concrete roles or concrete individuals. Anyway, all of that frames our work that I'm going to talk about today. So I've told you absolutely nothing new. I just wanted that to be our starting point. The National Academy for Social Prescribing wanted to set up an academic partners collaborative. And when we got together and we submitted our bid and we started working with the National Academy, this is the format that we proposed, and this is what we've been working to over the last few months. So up in the top left-hand corner of my hastily thrown together target diagram is NASP and a steering committee. They commission this work, they work very closely with us, and they have overall say about what we're doing and the ways in which we're doing it. Right in the centre of my target there are the core academic partners. We're the funded individuals that put together the bid, were successful in getting some money and have been working over the last 7 months to do the work that I'm about to tell you about. We comprise 8 institutions, there's 15 of us. I'll list those now. So we have the co-chair of the Social Prescribing Network, Marie Polly, who you'll be speaking to in a moment. From the NIHR at the University of Plymouth, we've got myself, Richard Bing, Sheena Asthana, Julian Elston, Lucy Cartwright. From the Centre for Evidence-Based Medicine at the University of Oxford, we've got Stephanie Tierney and Kamal Matani. From the University of East London, we've got Marcello Bertotti. At the University of Sheffield Hallam, we've got Chris Dayson. At UWE, Richard Kimberley. And from UCL, Helen Chatterjee. Sounds like I'm introducing a pop band, doesn't it? Although we're very different to that. The second layer of my target diagram are the people who are here today. This is the second layer, and the third layer are international audience, people who want to work with us, people who want to work with the National Academy, and this is anybody in the evidence around social prescribing. That could be in generating, creating, using, interpreting, communicating evidence for social prescribing. So there's a lot of academics in there, there's a lot of people working for universities, but clearly that's not the only people who are going to be interested in evidence or using evidence. So we really want those second and third layers to be as broad as possible, so that we can work with that cohort going forwards in terms of how do we communicate and use social prescribing evidence in the most appropriate ways. There's a little box drawn over that target diagram, which is the prioritisation voting group, and I'll say a little bit more about that in a moment, but that's the group of people who we went to tell us what were the most important ways we could focus our efforts over this 7-month project. That incorporates some of us, some of you, but also other people from the social prescribing system. So I wanted to make it clear where that group's at. That's the structure of our work. What we have done over the last 7 months is the following. We were commissioned to list or prioritise areas or categories that form the social prescribing evidence base. We prioritise those using networks and the target that I've just talked about, that group that cuts across all of those sections. We wanted to map the existing teams that were included in the core collaborative's work, and then we wanted to update that work using some researcher time. And from all of that, we wanted to produce systematic maps and evidence summaries, as well as a roadmap for evidence looking into the future. That's quite a grand plan for 7 months, but you know, I hope we will have achieved that and we will have done something useful, and we can talk a little bit about that in a moment. So core to all of this is the team that we've put together. When we were talking about social prescribing evidence, there were lots of teams up and down the UK that sort of knew one another, that had been working together in sporadic ways over the past few years. And this grant, or opportunity to work with the National Academy, was an opportunity to come together. So it's certainly not exhaustive, it doesn't encapsulate everybody who's been working on this topic, but what it does do is bring together some of those teams. So rather than the competition that's often core to academia, it's enabled us to come together and do something as a larger collaborative. And I think that's a really positive output, even just that in and of itself. So the collaborative work that we've been doing will build on that work, build on that strong team, and bring together our experience of systematic maps, of evidence syntheses, of policy-focused evidence communication, and hopefully try to create outputs that are as useful as they possibly can be for the people who are going to engage with them. That's policymakers, people in practice, people across the NHS, as well as other academics and other scholars. So the first stage of our work was to engage in a prioritisation process to try to understand where we should focus our efforts for this 7 months. The first step of that was to take the social prescribing diagram that I showed at the start of this presentation, those 4 boxes, and split that into about 40 topics that were in normal language, that, easily understandable language, that were chunks of the social prescribing system that we felt you could evidence. You could design a study that would provide you some evidence about what was working, how it worked, and in what ways. We took that list of topics, and then we wanted to try to understand from across the social prescribing system what was most important to people. So we designed this framework that tried to encapsulate that system, again using the diagram that I put at the beginning, and we got people to vote on it. So we had people from policy, we had people from the health system, we had people who were funding NHS and other services, we had other researchers, we had people who were link workers, prescribers, activities that were referred to, people from across the voluntary sector, and people who'd experienced social prescribing themselves. And we designed this table. So we allocated votes across the social prescribing system. We sent out an online survey with those 40 topics, and we asked people to prioritize for us. We sent it out to 95 people. We sent it out to 95 people. And as with all of these things, we got about a 50% response rate, which we were relatively comfortable with. We feel like we've got good input from across the system. And this is the list of things that people felt were most important to provide evidence to at the moment. So we were very honest, and we said we have the ability to produce 6 evidence summaries in the scope of this work. Where should we focus our efforts? And this was what people came up with. So we'll go into these in more depth in a moment, but it was around the economic impact of social prescribing. What are the sustainable funding models for social prescribing? What medium to long-term impact of social prescribing on individual health outcomes? What does that look like? Measuring outcomes for individuals receiving support through social prescribing was very popular. People talked about that a lot. And then how ethnic minority groups are accessing or not, or making use or not of social prescribing. And then lastly, who is and isn't being referred to social prescribing, so the demographic profile of people making use of these services. So that was our 6 topics, and the rest of those topics were also prioritised and will form the roadmap. So people also had other suggestions, and that's something that we'd like to work with the group of you here today to try to flesh out, looking to the future. How do we take these topics forward, and what other suggestions might people have for bits of the social prescribing system that would be usefully summarised in evidence summaries? And you can see people were interested in the impact on loneliness, social connection, what impact on the health and social care system, and then particular activities or groups as they relate to social prescribing. So while that prioritisation was going on, we piloted our methods for our evidence summaries. We developed a protocol. We conducted searches, screening, extraction, appraisal, and produced a pilot review relating to how social prescribing has been implemented for older people with dementia. And I show you the front page here. All of these summaries, in fact, will be going up on the National Academy for Social Prescribing website in due course, and we'd love to work with you to make those as useful as possible, get feedback on those. They will be living documents, as I understand it. So our pilot review tested our methods and made sure that we could usefully bring together very short evidence summaries on these topics. Following that, we split our 6 topics into what we've called platform and fresh or new reviews. And again, I'll say a little bit more about that in a moment. And we've also been developing our collaborative in all layers of the target that I described. So we've been trying to make sure that we're working with the right people. And then the third thing is to produce this roadmap that I've mentioned a few times, but it is the prioritised areas that we've listed in that order, but we've tried to link it to a method most appropriate for a study, and a funder where it might be appropriate to seek funding for doing that study. And we've done that for 2 reasons. One, to produce something useful for what academic research looks like over the coming years for social prescribing. But secondly, really to demonstrate that because it's a complex topic, it's a network of relationships, the answer to all of these research problems is not always a trial or not always a particular study. It is a really diverse set of evidence that you need to understand social prescribing. We want to make that really clear in our roadmap. So, to say something about our 2 approaches to how we've done our evidence summaries, we were aware when we were putting together our collaborative that the 7 teams that came together had huge knowledge around social prescribing and also had conducted large-scale research into a lot of these topics. We didn't want to duplicate effort or lose any of that learning. So when we got our 6 topics, we made it very clear to our teams that we wanted them to communicate what we already knew about this topic in a platform. So rather than going right back to basics and assuming that we knew nothing, we asked our teams with that research experience to summarize, synthesize, bring together what they already knew about this topic, but to also highlight the gaps, the areas where we didn't know things so well, maybe where things have been conducted a few years ago and needed updating. And we've used that as a jumping off point to then produce summaries that target gaps. So for our first 4 topics, our teams felt like there had been significant work conducted in these areas that they could bring together. And then we've used our resources through this project to update those searches, to look in different places for evidence, to contact different organisations, potentially look for different types of studies. And in that way, we hope that these 4 summaries will be up-to-date, useful, broad evidence summaries on these topics that don't duplicate that effort. And there's lots of reasons that that's a positive, but of course that does introduce, these aren't full systematic reviews. Had we have done 7 systematic reviews, we wouldn't have been able to do that in 7 months, of course. So those first 4 topics, the first one was around the economic impact of social prescribing. The team amongst our collaborative who knew most about that was Richard Kimberley, Marcello Bertotti, Chris Dayson, Sheena Asthana and Marie Polly. And then we updated those searches and we located 127 additional studies from Gray and database searches, and 5 of those met our inclusion criteria. So we've brought those together and we'll be presenting that summary soon. The second question was around different funding models for social prescribing. There's a lot of people on this call today who know a lot about that. And again, we'd like to take comment and input around this summary when it comes out. The team, again, who provided us with a platform for that was Richard Kimberley, Marcello Bertotti, Chris Dayson, Julian Elston, and Marie Polly. We screened 78 from database searches, 30 from Gray searches, and we included 10 additional studies to add to that platform. The last 2 questions both related to outcomes, but in very different ways. So we combined our searches and we built on the really significant work that Marie had done in the area, but also Helen Chatterjee, Sheena and Marcello Bertotti. And we've included 32 additional studies to add to that work, so we can bring that synthesis on top of the platform and present something we hope useful around medium and long-term impact for social prescribing, but also measuring outcomes around social prescribing. So they're the platform reviews. We also had 2 topics where we felt that we would be better placed to go right back to scratch and do fresh reviews. And I'll pass you on to Lucy now to say something about that. Lucy, you okay if I pass to you?
Yeah, thanks, Karen. Morning, everyone. I'm Lucy Cartwright and I work as a research assistant for the University of Plymouth. And I've been working on these reviews over the last 7 months. So as Karen said, we had 2 fresh reviews that we wanted to start on from scratch. And I just want to talk a bit about the methods that we've used for those. So as Karen said before, the 2 questions that we started with were, how are ethnic minorities accessing social prescribing, and who is and isn't being referred for social prescribing, so the demographic profile. We wanted to start from 2017 onwards, and this was so that we could reflect the current services for social prescribing and also to give us a balanced view of pre and post COVID. If I have the next slide, please. Thank you. So we started off by agreeing our search terms with our information specialist. So the concepts of demographics and ethnic minorities and different terms around social prescribing. She carried out our database and Gray literature searches for us. So for the ethnic minorities question, that came up with 17 journal articles and 19 from the Gray literature. Quite a lot more for the demographics question, 368 journal articles and 90 from the Gray literature. We had an inclusion criteria that we used, so including things like the date limit that I just mentioned. And we did 2 screenings. So we screened everything at title and abstract. And then from the ones that we'd included, we then looked at the full text. We discussed any disagreements that we had within our kind of core research team, and that gave us a final inclusion of 3 articles for ethnic minorities and 36 for the demographic question. Thanks, Karen. So we extracted quite a lot of data, so I won't go through everything that we extracted here, but for our ethnic minorities question, we were guided by the European Patient Forum's definition of accessibility. And we also included for demographics Progress Plus criteria to see if health inequalities were being taken into consideration. So we extracted all that into an Excel template and also critically appraised each article for quality. So at the moment, where we are is that we are synthesizing all that data and writing it up into our summaries. And the results are obviously pending at the moment, and they will be available. We will share that with NASP for publication at the beginning of October. So sorry, that was a bit of a whistle-stop tour. Obviously, a lot more went into it than that. So if you do have any questions, please do put it in the Q&A section.
Thanks, Lucy. And I should make the point, which I didn't previously, I've obviously removed that slide for some reason, that Progress Plus and health inequalities was core to all of our reviews. And we have sought, every time we've included studies, to try to extract data as it relates to any population that we feel may have experienced marginal gains through social prescribing, may not be accessing social prescribing. So there's lots more to say on that, and I'm sure we can engage in that in the Q&A. So these are the summaries that we're producing as a main output for NASP, as well as pulling together the collaborative that we've talked about today. We've talked a little bit about the studies that have gone into these summaries and how they're being produced. We very distinctly haven't talked about the results of these summaries today because, of course, we haven't finished our review work yet, and we need to make sure that we as a collaborative and NASP are happy with the things that have come out, that they reflect the reality of the evidence as it currently sits. So we will be putting those out into the public domain in due course, but we're not doing that today. I wanted to talk a little bit about how our 7-month project links to other national work that's currently going on. But before I do that, I wanted to say a little bit about how this work might look in the future. And that's something, again, that we want to talk about today. But we wanted to keep the Academic Partners Collaborative going into the future. This isn't a 7-month line, and we're not all going to disappear into the ether. We really want to keep, working together, but also working with all the people on this call and the other people in that target that I described. It's not absolutely certain how that will look yet. It's not absolutely certain in what format that will work. And that, again, is something that we want to talk to you about through the mentee discussion that we're going to have a little bit later. But there's definitely intention to do that. We really want to keep doing that. It's been a really useful experience. I think it's great in academia to collaborate rather than compete, and hopefully we can keep that up. Other things that are going on nationally that link to this work, you can see I've listed here. There is an evaluation of green social prescribing that's been funded by DEFRA. It's a process evaluation looking to understand how that rollout of green social prescribing is going up and down the country. There is a link worker evaluation that has just, I think, been funded by NIHR and will be starting relatively soon. That will run for a couple of years and try to really understand how link workers have been implemented across primary care, what the impact has been. The Social Prescribing Observatory, based at Oxford through Anant Jani and others, and funded through NHS England, is trying to capture SNOMED codes through primary care and understand referrals. Certainly through the pandemic, that's been incredibly interesting. And the Thriving Communities Fund that NASP have rolled out in the UK or in England also has an evaluation that runs alongside it. And we can make the links to any of those programs should anybody in this group be interested. We're happy to. We know lots of people doing these evaluations, and we're happy to make those links. So that's all we as a collaborative had to say to you this morning. The rest of this should be interactive, I hope. We can answer some questions, we can engage in some mentee work. I've put some links there. My name's Karen Huskell. Feel free to email me about anything. Our work at the University of Plymouth and Penark is listed as a link there. I've put a link to join the collaborative, but of course everybody on this call will have joined the collaborative, so that's completely null and void. So you can replace that if you like with Twitter. Please do feel free to find me on Twitter and tweet me. I find Twitter really engaging for this sort of work. So I'll stop sharing now. Welcome everybody else back. Hi Marie, hi Lucy. I wonder, we're about 4 minutes to 11, so we're about 4 minutes early, but that gives us a little bit more time for questions. I haven't been able to keep an eye on the questions because my slides have taken up the whole screen. Is there anything coming up? Helen, Marie, Lucy, can anyone see anything?
There aren't any questions posed at the moment, but people may be sat there thinking, maybe I want to ask that, but I'm not sure if I should, but I just encourage you to. And whilst people are wondering what they might ask, can I just tell people that on the toolbar at the bottom, if you see a smiley face, it has lots of emojis when you go into it. And when you click the emojis, it gives you like these little things that come up on the screen. So as we're speaking, you can send us a few little messages if you would like. So do feel free to have a bit of fun. Here we go. We've got a few things going. So, oh, lovely. See, that permission to have fun in a serious situation is always good. So I'm not seeing any particular questions at the moment. Somebody said, could we share the slides? So I'm presuming that everybody's happy for the slides to be shared, because I think that will be really useful. And this is being recorded, so if everyone's happy, we'll be able to put the recording out as well. But yeah, so whilst we wait, maybe I'll move forwards and then people can still pose questions. So we're going to move into kind of a little bit of an interactive session. So you've got a mobile phone near you, you're going to need that soon, or another tab open on your computer if you can juggle that, see how it goes. And we've got some questions that we're going to do through Menti, and you'll be able to kind of live poll your answers, and we'll look at the answers as they come in. And it's really about how do we want to move forward with this collaborative. So I've really enjoyed, before we started the presentations, I've met 3 PhD students who are in their first year, one from Germany, 2 from the UK, who are working through their methodologies. And everyone that's done a PhD understands what that's like, reading lots of literature and trying to work out how you're going to do your research, and in fact, what is your research going to be on. So it's just great to connect people, isn't it? And so when we finish these presentations, you'll see all the tables come back up. And basically, if you just go and put your cursor over a table and kind of click on it, you'll sit down at a seat, and people will see you're sat there, and probably someone will come and chat, and you can just work around. There's 8 or 12 tables, so do feel free at the end to just use that time to go and talk to each other and meet people, because you'll find lots of connections. And that's, as Anne said at the beginning, part of the point of this is just actually see who else is out there doing that research. And also I want to say thank you to Helen Sears, who is behind the scenes today. So Helen's done a lot of research with me in social prescribing and lots of stuff, and she's actually just very kindly hosting us all behind the scenes. So just thank you very much, Helen. So I think that what we'll do is we'll move on to Menti. So Helen, if you would be kind enough just to pop the slide up. So in a moment, here we go. You can either scan your phone camera over the QR code, and I'm going to be doing this at the same time, or you can just go to menti.com. And when you go to menti.com, you need to put a number in it. It'll ask you for a number, and we've got the number here, 27178819. So I'm just going to do menti.com on my phone, menti.com. And when you join it, you should see a question. So menti.com. All right, join it. So it says on my phone, it says, please enter a number. So I'm just going to put that code in now. So if you're all doing that at the same time, that's going to be fab. Submit. Yeah, and then it gives you the first question. And we're going to actually go through these questions together. So I think if we just write in the chat, so hopefully people are getting on board. But if I just do Menti, if I can type in the chat, menti.com, and then the number is 27178819. So Helen, I've put that information in the chat. So if you want to share Menti with us, Helen is kindly juggling. Anyone that does all this stuff knows that screen sharing and everything, we just sort of juggle through the technology. But in a moment, we'll start to see what Menti looks like. Here we go. So these are questions that we thought about with Anne. So as part of NASP's new UK and International Evidence Collaborative, would you like us to offer opportunities that? And we had to think, what sort of opportunities might you like as a researcher? When I did my PhD, which was in a completely different area, it's sort of PCRs, DNA, all of this stuff and cancer. Actually, I was the only one working on it, and it would have been really nice to have had lots of people to talk to in the same field, but they were all in America. And when I did my PhD, the internet was only just getting started. So very different world. I'm that old. So you might want us to help deliver a shared strategic research agendas, or it might be shape effective evidence products to support decision making. Might be act as a critical friend for informal peer review and project proposals, grant applications. You might feel that we want to, could we work together to build capacity around delivering high quality research and evaluation? Could we be connecting schemes to their local universities or local research organisations? Be part of a network for social prescribing evidence champions and mentors. So we've got quite a lot of people, so you can tick all that apply. So we're just going to keep on this question for a while, because I know there's 42 people in this session, and I can see in the bottom right hand corner 32 people have managed to get into Menti. So you just go to menti.com, and in the chat there's the code that you put in, 27178819. And I think what we'll do, because we've got about 200 people in the APC at the moment, we'll keep this open and we'll send it out to the whole of the APC to give more people a chance to vote. And then I think, Anne, that will give us a more representative view. And then Anne's going to look at this, and actually this helps Anne chat with everybody at NASP to say, how do we go forwards? What would be the most useful things to actually be providing for everybody? And I'm just going to give it maybe 30 seconds on this question, but also I'd just like to say it's really great to see Sean here from Australia, and Kate from Canada, and Janet from the US. And we've got Sina from Germany. So I don't know who else is here from beyond the UK, but it's great to have you with us as well. I'm not sure what the time zone is in Australia at the moment. Hopefully it's not too late at night for you, Sean. Brilliant. Right, well, we've got 36, so we're getting there. So Helen, can I ask you to move us on to the next question? So would you be interested in coming together again, like this, hear more about the evidence summaries, and help us shape the roadmap for future evidence needs? So that's the very simple, should we do some more of this sort of stuff? Yes, no, don't know. Or maybe say, no, it's rubbish, go away. We don't want. So we'll just, so that's a reassuring result so far, Anne, isn't it? To see we've got people saying yes. And once you get the hang of Airmeet and you can move around tables, it's quite good fun, because you can just drop in on people and you see who's sat where and stuff. So brilliant. So that's really, really helpful, because actually just literally having this gives Anne a really good bit of data to take back to people that are looking at how the money's spent in NASP. Brilliant. Well, nobody's even saying I'm unsure. And we've got a question coming in. So we'll finish the polling, and then we'll have a look to see if there's any other questions that come in as well, and we'll see. Brilliant. This is really good. I think it's quite nice to see what other people are thinking as well, isn't it? So just 30 more seconds in case there's anyone else left that wants to vote, and then we'll move on to the next question. I must submit my own answers as well. Mustn't forget. Right, Helen, would you be kind enough to move us on? Thank you. So how else could NASP and its core academic partners that Karen kindly listed earlier, how could they support you as either a researcher or somebody that really values, needs to use the evidence? How could we support you to advance and share the evidence for social prescribing? Now, this is for you to put your own comments in. So what would help you? And just, there are no boundaries to this answer. So what would help you? Right, so, and things are going to start to pop up, so this is really great. So distribute evidence summaries for clinicians and delivery partners, brilliant. And I think the evidence summaries are designed for that. It takes a bit of a while to get evidence summaries rocking and rolling and moving forwards, and then it can become a process. So really good stuff here. Ensure simple language, totally agree. When I set the network up, we banned acronyms because if you work across sectors, 3 letters mean lots of different things to people. Mentoring early career researchers. Infographic materials, brilliant. Economic data. Some social stuff to go on social media, so graphs that present data visually to go on social media, brilliant. Subgroups, so almost like special interest groups. Perhaps we have some special interest groups in the network, so that could be really good, special interest groups for researchers. Academic staff and students being involved in evidence capture via collaboration. Totally agree, collaboration is so important. And actually collaboration makes your research more efficient. Cost benefit data, yeah. And hopefully as we get the evidence summary, then we'll start to see that. It would be good to know as a researcher, oh Helen, just scroll down ever so slightly, that's it, good, down, other way, up, yeah, thank you. It'd be good to know as a researcher, current research going on, to avoid duplication and potential for collaboration. I totally agree, and something I've thought about, haven't got around to doing, setting up like a database where you could just say, this is me and I'm doing this research, and people would automatically see that. Oh, we've got little thumbs coming up as well. Support to interpret the data we collect. Yeah, really good thoughts there. Host meetings in different regions and explore how to use evidence in practice. Hyperlocal evidence. There's something really interesting, isn't there? We need system evidence to really inform policymakers to invest, but actually we do need hyperlocal evidence because each area that has social prescribing is unique. So hyperlocal, whether that's hyperlocal in Australia or Germany or in the US, or whether that's hyperlocal in Ireland or Scotland or Wales or England. Impact stories from clinicians who are best advocates to other medical folk. Great. Best practice collaboration processes. Yep. Really clear, robust evidence, including indicators of uncertainty where evidence is not strong or conclusive. Yeah, I mean, that's almost as important, isn't it, to say this is where we know there's evidence and we're pretty sure on this. And these are the areas where maybe evidence is emerging, but it needs a lot more. And I think it's a fine line to walk sometimes. It certainly felt like a tightrope in the early days of setting the network up and briefing the government on what we could confidently say and what we thought looked good, but we wouldn't, you know, I wouldn't want to be held to it because things can change. So there's something here about routinely collecting NHS data to use as control or comparisons for interventions. And I think that whole idea, I mean, we could do a whole session about the pros and cons of how you have comparison groups and control groups, and whether you can have a control group that doesn't get compromised by more social prescribing rolling out, or what databases already exist that perhaps have data that already have a bank of data that you could just get a sense of and compare to. Or Helen and I have done case matched controls. So there's all sorts of approaches and they all have their pros and cons. So headline information, yeah, definitely. Opportunities to share findings, prevent duplication in a non-competitive way. Love that. So actually, I spent about 4 years as we started the Social Prescribing Network saying it's about collaboration and not competition. And academia particularly is set up to compete. You're competing all the time. And as a collaborative, we made a decision to collaborate, and you still need to get the grants to progress your careers, and we understand that. But actually we can do that collaboratively, and it's a lot more fun and it's a lot nicer. So I think collaboration is so important. So mixed methods and some simple frameworks for VCSE to use. Brilliant insights into new methods which are suitable. I think that's really important. I think in the first research conference we ran, I think that was 2017 in Salford, actually we did this live polling, and I think there was almost a unanimous feel for having more pragmatic research methods and realist research methods. Of course, once you get a really good bank of data, and once this field, which has really emerged now, becomes solidified with data, you have enough to then design comparative effectiveness studies. You know what your kind of effect should be. So if you've got outcome measures, you should know what type of change in scores you get. When you get to that stage and you have good statistics for powers, then you can actually start to design some trials. I think we're maybe a few years away yet, but I think then, you know, so actually exploring how we take the knowledge we get from qualitative data and maybe new theories that emerge from that and people's voices and reflecting inequalities and bring that into design of quantitative studies and mixed methods. I think it's going to be an exciting area. Have you got any other thoughts? It's kind of scrolled away. So train and inspire practitioners and facilitators to gather data efficiently. Yeah. And I think probably one of the biggest tensions along with sustainable funding in social prescribing is actually how do you collect data that's good quality? And what's the difference between that kind of service monitoring data, which should be minimum amount collected, that actually shows the service is doing what it's meant to do on a day-to-day basis, and that's governance and quality assurance, compared to doing that deeper dive, which a lot of you are embarking on at the moment, to really understand a lot about a particular bit of social prescribing. And, you know, research is done by researchers. They're not usually practitioners running the day-to-day schemes, and they're not link workers. And we have to really be clear about what is research, what's monitoring, and make sure we don't burden link workers with trying to collect lots of data. What else have we got? So you're still going, it's great. So once you start thinking about this, hopefully you're like, oh, and actually there's this as well. Adapt innovative research methods to the context and to the participants. Yeah, definitely. And we're working with very vulnerable participants as well. And I think that adds a dimension to the ethics as well, doesn't it? Don't underestimate the value of data collected by non-academics. Absolutely. I mean, technically, I am now not an academic. I have a visiting readership at UEL, but I don't work as an academic anymore. And I think it's not about where you're housed. It's about the quality that you bring to the method that you use, and that doesn't, like you say, that doesn't need to be an academic institution. But in academia, there is something that I think is really important. It's about having a quality bar. So the whole idea of having peer-reviewed publications means that it has been looked at other people in the field. And usually a publication peer-reviewed is better than the one submitted before it's been peer-reviewed. So I personally think it's about having quality to everything that we put out as well. Sharing what doesn't work as much as what does. Yeah, first do no harm. And actually, when I was in sort of the molecular biology field, it was very hard to put negative data out or data where we said this didn't work. And actually, if you're doing sort of genetics and cloning that I was doing for a while, it'd be really great if someone had said you can't do it like that, and save you a lot of time. So I think there is something about being able to have a space where maybe we come together as researchers and we say, actually, we tried this, but it didn't work, and we realise in hindsight, you know, there were some things we hadn't thought about, or we've had to adapt. You know, there's a lot of adapting to how you collect data as we come out of the pandemic. So that is, yeah, being able to say and do that. Anything else that you think you want to put in there? Give you 10 seconds more. So we will circulate the Menti link to people that weren't here, and they can also add their stuff, and then there'll be plenty of information for Anne to have a look at and the collaborative to have a look at. But hopefully, Anne, this gives you an idea of some things to go back to NASP about, and as a collaborative we can maybe prioritise some areas. And so Helen, go on, Anne, do you want to say something?
Yeah, I was just going to say thank you very much for all that feedback. So there's already some clear themes emerging there for me anyway, around that sort of need for collaboration and enabling that collaboration to provide simple ways for people to improve how they capture data and feed that in, including from local. So that's come up as well. That's how do we feed that local input in, and that whole thing about sharing. So how we can be clever about how else we use our other teams around us, like the comms team in NASP, you know, that are building teams of ambassadors for us. So how can we feed that in to help amplify what we're doing and what we're finding?
Yes, brilliant. Thank you, Anne. So I think that Helen, if you don't mind, we'll come off screen share for now, and just really appreciate everybody's input into this. There is a question that's come in, and I'm going to open it to Anne or Lucy or Karen. So Christine's keen to know how the local evidence feeds in that's collected by so many social prescribing schemes. So any thoughts, you three?
I'll have a quick answer, because it's such an important point. And the honest answer is as much as we possibly can, but it can be very difficult to keep access to all of those data sets. So as Marie's just said, where data is collected, whether it's inside, outside academia, all of that kind of stuff is generally irrelevant. We know that social prescribing is so complex. We need evidence however it is collected, wherever it is collected, and relating to different parts of the system. So we've definitely tried to be as broad as we possibly can be. So in these evidence summaries and in other work our teams have done, we search the peer-reviewed literature, we search databases, but we also search the grey literature. We talk to people. We have lots of connections and networks that we can make use of. So we talk to people who really understand these systems, and they're the people delivering systems, and they have data sets and evaluations that they know about. So we make sure as much of that feeds in as possible. However, of course, there's a resource and a time cap. We can't spend our lives doing a single review. So we try to put out evidence calls, and we try to incorporate that. The second layer of my answer would be that at a local level, each of our teams in the Academic Partners Collaborative work really closely with the organisations delivering social prescribing in those areas. And so those data sets that you mentioned will feed into that work. I'm absolutely sure it does for us down here in the Southwest. It does for our colleagues in Oxford, for Marie, for others. And so those data sets really help us understand how things are working, but also to then communicate back to services how we have seen other things in other areas, to hopefully share that learning and spread that learning. And then through those data sets, communicate to people like NASP what's currently going on, because it often doesn't match NHSE policy or other national policy. So trying to communicate in both directions. So my answer is as much as we possibly can, but sometimes it's difficult to do it as much as we'd like.
Thanks, Karen. I think I think that's a great point to make. And actually, if I can add to that, I think certainly with the Social Prescribing Network, the steering committee sit on quite a lot of task groups that are associated with the policy development, link worker professionalisation, and we always have worked with people. So we constantly feed bits in and saying, actually, so-and-so's doing this over there, you might want to talk to them. So being able to have those sort of eyes on the ground. And as people send us stuff into the network, we send it out or move it on. And something that's becoming really important, actually, which I think is probably very relevant for research, is actually when you're writing research grants, I think it's really important that it's not always easy to co-produce the grant, but you need every voice represented, and actually having the citizens involved in grant writing. But actually, I spend a bit of time with the network hat on, reaching out to people and saying, we're putting an NIHR grant together. It's about this. Can you tell me what's happening on the ground? What bits of local data have you got that we can feed in to shape the grant, to make sure that what's written is shaped not by just a few reports that we may find, but actually there's often a lot more data that's not reported, but we can do a little bit of connecting with people. And I've done that for a grant around dementia and social prescribing recently, and connected with people across the UK to then be able to feed in. And then when the reviewer comments come back, we've then gone back out to people to double check before we then respond to reviewers. So I think there'll be more of a role of that actually going forwards. So yeah, so there's lots. Anne, come on.
Yeah, it's just very quickly to say, I think, yeah, going forward, especially once we get the evidence summaries and the roadmap, we'll identify where we've got gaps, that maybe then through our network, including programs like Thriving Communities, we can identify where we really need to build up our evidence base, and that's where we may need to gather it very locally. So, and find ways of doing that between us.
Yeah. Karen, did you have another thought?
Just as a last point on that, I guess the thing about local data is that it can prevent duplication, and we need to find a way of being better at encapsulating what we already know, so that we don't have lots of grant applications submitted for things that we probably already have in data sets that are sat in people's desks or computers. So I think, you know, being a bit more robust in what we already know and what already exists in these data sets is probably useful, but that, you know, wasn't it ever thus, I suppose.
Can I, as a question from Dragana, who's at the University of Essex. Oh, brilliant! I don't know how you did that, Helen, but that's really very cool. So here you go. Can you comment on gaps in evidence in any particular areas that you might come across? They found very little work of evidence on impact of social prescribing on social care. Yeah, Dragana, there is very little about that at the moment, probably more in Northern Ireland actually. But Karen, Lucy, have you got any thoughts on evidence gaps at the moment?
Yeah, it's a great question, and this is definitely something that we want to communicate through the evidence summary. So there is a more detailed answer to follow as these come out, but it won't come as much of a shock to anybody on this call, I don't think, to know that the gaps that we've identified are the ones that we probably already know exist. So, for example, we know less about how young people interact with social prescribing services, or more to the point, how might social prescribing services work better for children and young people. There's clearly a benefit to be had there. How do we position social prescribing? So we know a little bit less about that than we might do. Another gap really is around ethnic groups or groups for whom accessing social prescribing hasn't historically been in as many numbers as other groups. We know less about the nuance, about the ways in which different groups interact, how that interaction is framed, how social prescribing might be better framed for different groups of people in different ways. And then the last point I'd make is one that Marie's already mentioned, which is about we know less about how things don't function for people than how they do function. Yeah. Social prescribing evidence is currently relatively positively framed, and that's not a criticism, it's a recognition of the fact that that's the way the evidence has been generated, because they come from evaluations for funders and program managers, and also to convince commissioners that there's something in here that needs funding. But it's so important now that we look to understand when things don't go as well as they might have, how they don't function for different groups, when people fall off between different providers. So there's those gaps, I think, that I would immediately recognise: young people, ethnic and other minorities, and the less positively framed stories. Others may have more. Yeah.
Thanks, Karen. And I think the people that what is very hard to research, but actually is really important, is who doesn't take up the offer of social prescribing. Because if you only collect the data from the people that do, you end up with informing policy that just works for that particular group of people. And I think, you know, going forwards now in the next few years, there needs to be more of a look at why didn't people take it up. So we know sometimes people have a short conversation, say with a GP, and they don't get enough explanation about social prescribing. They're kind of just referred on, and it's all a bit baffling, and they don't know what it is, and they end up with, you know, just think, why am I going to go there? I don't know what it is. Or they've been referred, and maybe it wasn't that referral wasn't quite appropriate. So then they get to the link worker, and then they think, actually, no. And we know that coming out of COVID, actually some people have waited, they want face-to-face. So there's various things, but it's really, really important. Helen and I did evaluation work years ago, and we actually went back to people that had not taken part in a service. And we said, is there any particular reason why you didn't take part? And between us, we brainstormed 13 reasons, like people might have moved, they might have gone back to work, all sorts of things. And we wanted to know if it was a problem with the service, actually. And actually, I think 98% of people said life is why I didn't go and use the service. But then they were invited to go to the service, and 50% of them then took it up. So often it's just things are happening. But what can we do to design social prescribing in a way that mitigates against the barriers that life throws up? I'm just thinking, we are due to finish at past, aren't we? And then we'll go back to networking for half an hour. So I just had a couple of things I just wanted to share. So we're hoping to launch the 4th International Social Prescribing Network Conference this week. So I'm just waiting for confirmation that the booking system's live. And this conference is a global conference, and it's 2 days in March, and we'll be sending information out via the APC and stuff. So that's happening. And in 2 or 3 weeks' time, thank you for those lovely party emojis. In a couple of weeks' time, we'll be opening the submission for abstracts. So the abstracts get submitted for the conference and they're peer reviewed. And from that, we choose the speakers for the conference. We choose speakers into particular areas, and we choose posters. So it is a great place to share your research with. So I wanted to flag that. And we're going to send you details of March Network, who have got a showcase event for social prescribing in a couple of weeks' time. And the March Network has been another big collaboration, and they're coming to an end, but they're morphing into something even more exciting. So we'll send you the details of that, and we do heartily recommend that to you. Kate, our friend Kate from Canada. Hi, Kate. Could you comment on what we know about the role of person-centeredness ownership by the participant in social prescribing? Karen, would you like to have a think on that one?
I think it's a great question. Hi, Kate. Sorry, it's a really early morning start for you. It must be 6:30 a.m. or something. So I'm sorry we've got you up early. I think this is a great question, and I think we could probably have a nice hour-long seminar on this. And if we're thinking about a seminar series, this is a great topic. For me, especially, I think there's a few things. One is that certainly in the UK, the move towards person-centeredness is the root of social prescribing. This is where social prescribing comes from. The policy and the move in the health service towards person-centered treatments, person-centered options, or putting the individual at the centre of the health service, really is the framework and the building blocks for social prescribing. Social prescribing isn't new. This isn't something that emerged in 2016, completely fresh. This has been, in general and family practice for, decades. And that move in policy towards person-centeredness, the NHS moving towards person-centered care, the universal personalised care that James and the NHS team put out, all of that coalesces together, and social prescribing reflects and is part of and is core to all of that understanding about how we should deliver healthcare. The second layer is that clearly ownership and person-centeredness, as you rightly point out, is a mechanism by which social prescribing may have some benefit, and there may be some there are some really interesting research topics in there. Is it a mechanism? Is it a context? Is it does social prescribing provide the platform for people to own these things, or does social prescribing encourage and therefore become the mechanism? There's some really nuanced questions, and I have to say at this point I probably don't know the answer as well as I might, but I think it'd be a really interesting thing to collaborate on. And what you might have highlighted is a really nice Canadian UK seminar that leads to a little grant application for us to try to pull some of these things apart a little bit more. I don't know if anyone else has got something more coherent to add, but it's a really nice question.
I had a thought, because actually I don't see them as synonymous. I kind of see there's person-centered. So my experience in sort of person-centered stuff for 20 years, when it wasn't cool to be doing it and you were sort of bashed over the head for doing it, is actually that's the approach to hearing a person and having them alongside and focusing on what's important to them. And that's where our kind of my core measures came from. I often see in the research data and the stories that person-centered approach gives a person a trust and a relationship and feels like they can be heard, And then when they feel like they can be heard, I think then you step into a level of ownership. So the ownership of, this is me, this is my world. I'm ready to then feel like I want to do some stuff that's better for me and connect, and then take ownership in having a voice into maybe the community. But I think that comes because people take the time to be person-centered. And I think that person-centered approach is really gaining strength in the UK. And it is very different to a paternalistic, hierarchical, I know what's best for you, unless you're in A&E. Because I would, quite frankly, if I was in A&E and I was in a critical state, I'd want people to be nice to me, but I'm not going to negotiate the treatment plan. But for long-term conditions and where people have got lots of other complex issues going on in their life, it takes time, doesn't it? And it's very hard not to judge a person as you see them. And I've heard in the data as well, stuff that really, I think really inspires me in the social prescribing area is people saying, I'd never told anybody, I'd never talked about this before. You know, they might be 50 years old, they might have had a shocking childhood, had abuse, had all sorts of things happen, and they're with a link worker, and this approach has allowed them to bring these barriers down and actually start to explain the things, and then they get the needs sorted out over time, you know. So yeah, so I see one going to the other if we get it right. And I think that that's probably a really good topic to take you into discussions on yourselves. So in a moment we're going to end this section and you'll see the tables come back up. So what I want you to do is just hover over a seat on the table and press your cursor, and you'll get on a table with other people and see how many new people you can meet and establish the relationship. So Anne, is there anything you'd like to just end with? Can I give the final word to you?
Oh, thank you, Marie. Thanks to the speakers. Thank you very much for sharing that with. Thanks to everyone for your time. There appeared to be a very clear steer that this was useful for people and we ought to do it again. Karen and Lucy proposed that the next one we offer to share what we found through the evidence summaries, and then perhaps we could do more Menti about other things, you know, seminar topics and other things. I'm unpicking what the first Menti told us, so would that be all right? So we'll get back to people. So thank you to everyone for the time. Please enjoy the networking, and we'll see everyone very soon.
Thank you, everybody, and continue using the chat as well. So sorry the questions started to come in as we're finishing. But Helen, if you would like to end this session, and we'll pop on tables and say hi to people. So thank you, everyone.